Welcome to the Emergency Medicine Cases podcast. I'm your host, Dr. Anton Hellman, bringing you the brightest minds in emergency medicine from around the world. EM Cases is brought to you by SHREMI, the Schwartz-Reisman Emergency Medicine Institute. That's a nonprofit organization dedicated to improving EM care through high-quality research and education. The opinions expressed on this podcast are intended for information and education purposes only and should not be used to diagnose, treat, or prevent any medical condition, nor should they be used as a substitute for medical advice from a qualified practicing physician. This episode is brought to you by Easy Resus, the resuscitation assistant. This amazing app has drug dosing, equipment size calculation, treatment algorithms, all in under 3 clicks. Rapid access to life-saving critical info in a user-friendly interface. Try the app for free with the promo code EMCases or visit easyresus.com/EMCases. That's easyresus.com/EMCASES. Bruce Lee famously said, "I fear not the man who practiced 10,000 kicks once, but I fear the man who has practiced one kick 10,000 times." When it comes to the trauma airway, RSI is our go-to technique for most of us, and we're pretty comfortable with it, and some of us have done it not 10,000 times, but maybe hundreds of times. So when we're in the heat of a big trauma, it makes sense to go with what your mind, your muscles, and your team know best, and that's probably RSI. But alas, it's not so simple. The big question is, when should we deviate from our primary technique? And if we do deviate from RSI, what technique should we use, and what should the timing of that technique be? The timing depends on the anatomic, physiologic, and psychologic airway challenges that face us with each case. We need to know not only how to manage the airway in the polytrauma patient, but how to manage trauma to the airway itself, whether that's a blow to the throat or an implement going into the neck. So, to help us answer these big questions for our big trauma cases, we have 2 guest experts and trauma team leaders who you've almost certainly heard before on EM Cases, Dr. George Kovacs, our go-to airway expert from beautiful Nova Scotia, and Dr. Andrew Petrosoniak, our go-to trauma expert from Toronto. Great to have you both back on the show. Welcome, gentlemen.
Great to be here.
Thank you, Anton. It's great to be here.
All right, well, let's start with jumping into a case. A 25-year-old woman rolls into a resuscitation bay with an obvious neck wound just off the midline in the anterior neck, a so-called Zone 2 injury. You hear gurgling sounds. Take a quick look at the EMS monitor that's still on the stretcher, which shows a heart rate of 145 and an oxygen saturation of 90%. EMS tells you that this unfortunate woman woke up this morning to discover her boyfriend plunging a kitchen knife into her neck. You're planning your resuscitation and airway strategy. I'll just pause there. Before we dive into the airway management for this case, I'd like to refresh our listeners' memory about resequencing the trauma resuscitation. We chatted in detail way back in one of our trauma episodes about this concept. Basically, the idea that sometimes our resuscitation needs to follow an ABC sequence, sometimes a CAB sequence, and other times a BAC sequence, depending on the immediate life threats that we suspect. So, Dr. Petrosoniak, let's start with you. Can you refresh our memories and explain the thinking behind this concept of resequencing the trauma airway as a framework for our discussion on trauma airway?
Obviously, we love letters that go in a way that makes sense for us. So ABC has been where we've kind of focused. It's been where CPR originally started, or cardiac arrest management, and as a result, also the management of trauma patients. And that's gotten propagated through ATLS, and it gives a structure, it gives something to lean back on when we have a bit of uncertainty. Superficially, it makes sense to start with the airway and then move down the breathing and then circulation, and you can kind of go from head to toe. And all of this fits with how, our minds work, and overall we are simple creatures. But unfortunately, when we're injured like this, humans don't behave necessarily so simply or so typically, and that there may actually be a bit of a problem in following this kind of approach. And I think A, then B, then C is a reasonable approach when you're trying to briefly evaluate what injuries might be there. Where we've run into issues is when we decide that the management can't proceed until A is managed and then B is managed and then C is managed. And so unfortunately that nuance was, I think, lost a bit in translation, propagated through ATLS. I don't think it was ever intended to be that way, but that's kind of how it's been described. So when it first came out, it was like, yeah, you should evaluate the airway, because if you don't have an airway, you can't really kind of continue. That said, if you don't have a blood pressure, it's pretty hard to, that should be managed simultaneously as well. And so that's where this all has come from. We have, over the last probably 10, 15 years, taken this approach of resequencing trauma resuscitation. The idea of CAB has really gained traction both in non-trauma cardiac arrest as well as in the trauma resuscitation phase. And what this means is, what we're really trying to do is quickly address the greatest threats to life and then customize the resuscitation as a result of that. And so if that means that you are going to check the airway first and then the breathing and then the circulation and follow that, I think that's reasonable. Ultimately, though, if somebody's spurting blood out of their brachial artery, the timing for managing the airway, it's going to be pretty obvious that you just need to put a tourniquet on that patient's arm first, and then you'll come back. And intuitively, you're probably looking at their airway briefly to be like, well, do I need to do that at the same time and manage that airway? And so we have moved towards this idea of perhaps a CAB approach, or maybe it's CBA, depending on what's exactly happening. But that's really around the course of management rather than the evaluation. The evaluation probably happens within 20 seconds, 30 seconds, and is pretty much done in parallel rather than in sequence. But really what I think we're mostly looking for are two questions. When I immediately see a patient, is there massive external hemorrhage such that my shoes are getting soaked with blood and I should probably fix that right away? Or is there severe airway compromise? And what do I mean by that? And George will, weigh in on this. But I'm going to briefly evaluate the airway such that, is there a dynamic airway? Meaning if I wait 5 minutes and I come back to manage that airway definitively, it won't be there. Because in a case like this that you just described, the patient's penetrating neck injury, they have massive swelling, and you come back in 5 minutes and you've been doing other things, and now no longer can you manage that airway because you've completely lost it? Or is there such critical hypoxia that despite a non-rebreather, despite some initial brief attempts at oxygenation, that you're just watching the oxygen curve, you're just falling off that curve? And so for me, those are kind of how I approach this. I look at, one, is there massive external hemorrhage that I need to manage immediately? Two, is there severe airway compromise? And to me, that's a dynamic airway or critical hypoxia. Beyond that, now I have a moment to pause and just say, okay, let's go through this sequentially, evaluate, airway, breathing, and circulation in a bit more of a systematic way, and then customize the resuscitation based on the greatest threat to life. If the greatest threat to life is hypotension due to hemo or pneumothorax, then the focus is going to be on addressing that. If it's because there's a pelvic fracture, I'm going to bind the pelvis. And so it's a customize, and you focus on the physiologic priorities rather than A and then B and then C. And we all know that not resuscitating a patient prior to intubation can certainly put that patient at risk for harm. And so you do your very best to ensure that that patient is resuscitated or is getting resuscitated as you need to manage their airway.
Fantastic. I love how you summarize that. I just wanted to sort of rephrase it a little bit. So there's two questions that you need to ask yourself, but in addition to that, really it's about assessing for the need for the relief of obstructive shock. And in that case, you'll probably you'll do bilateral finger thoracostomies if you suspect that there is obstructive shock. So I guess it's assessing for the possibility of obstructive shock. And in that case, you'd go for the bilateral finger thoracostomies first. And then the two questions that you mentioned, which are, is there massive external hemorrhage, or is there airway compromise that's critical? And that's divided into either a dynamic airway like we presented in the case, or critical hypoxia with the SATS diving.
Anton, I would just say one other thing. I mean, with respect to relieving obstructive shock, and It may also, the other, the big obstructive shock that should scare all of us, and this is deviating a little bit, but it is pertinent in the management of the airway, is the patient that has tamponade. You may require an operation to relieve that. And in those cases, you may then want to pause your efforts on intubation, and that should probably be done in the OR if the patient still has a blood pressure. Obviously, in the event that they have a cardiac arrest and you believe it's due to obstructive shock, you'd proceed with a thoracotomy typically. But that is sort of the one thing that should, put fear in all of us as we intubate a patient. If you think that they have tamponade, then proceeding with intubation should be done carefully or not at all, unless done with a surgical plan kind of simultaneously.
Absolutely. Yeah. Thanks for clarifying that. I forgot when I mentioned obstructive shock, I only mentioned tension pneumothorax, but for sure tamponade is on that list as well.
The reality is that, it's great to have an alphabetical approach, and whether we put C before A or F before B, it doesn't really matter. It's about you're surveying the room, you're surveying what's going on, and a lot of things are happening simultaneously, right? So again, from an access for managing the airway, you need IV access most of the time. So all of this is happening simultaneously, and you're going to address what is overt and you need to do. And as has been said by Andrew, if they're exsanguinating from somewhere, then that's what you got to manage. And it's really rare that you have to do a crash airway. It is uncommon. The thing we need to remember is while we're trying to find an algorithm and somebody is acutely ill, that we do need to slow down. And the message goes back to COVID days. And that was one of the big learning points that came from that. It's all about prioritizing oxygenation, ventilation, and maintaining physiologic homeostasis. And as Rich Levitin has said, patients don't die from acute plastic deficiency syndrome. They don't die because you put a piece of plastic as a conduit in their trachea. They die because we're not prioritizing what they need at a cellular level, what they need to keep them alive. And that's going to be an overarching message from my point of view today. It's not about the tube. It's what you do in the resuscitation room, the things that Andrew's already talked about, and referencing those priorities.
Absolutely. So it's about prioritizing all those different things at the same time, getting things going in parallel, and slowing down, that we don't need to run for the ET tube for every patient. And certainly in trauma, we're much more often actually delaying any intubation, if at all, for other priorities.
The only crash scenario, the thing that you have to do, and this is somebody that again, you don't have to follow with tracheal intubation, but if you need to open their airway and apply oxygen, as long as they're breathing, right? And if they're not, then you're going to assist them. But that's the only sort of immediate airway intervention that we need to sort of prioritize. The getting on to tracheal intubation is going to happen sometime later, and whether that's in a few minutes, 10 minutes, 15 minutes, a half hour, or in the operating room, that's something we'll determine as the patient responds to what we're doing.
So one of the questions we've raised so far is when to intubate the trauma patient, as you just alluded to, and if we need to intubate the trauma patient at all. So, Dr. Petrosoniak, can you zero in on some of the key variables that you consider in your decision of whether or not to intubate in the first place? Like, when is intubation indicated in the polytrauma patient?
Sometimes it's so blatantly obvious, and sometimes it's so very difficult. And putting an endotracheal tube in doesn't just solve all of the problems. It certainly can make things much easier, but it is done and it has risks. There's downsides to intubation. And so it should be done thoughtfully and carefully and with a reasonable process. And this is the art of medicine. And there are times, and I can think of one about a month ago with a patient who was intoxicated, and I kind of stood around the team and I said, we're just going to take a vote. I'm curious, what do people think is likely going to happen when we go to CT here? Because it was a blunt trauma patient that needed a CT. And it was on the borderline. The GCS was altered. It was confounded by alcohol intoxication. So it was very difficult to predict, like, could we get to CT or not? And I kind of said to people, what's the probability you think that we're going to have a problem in CT, whether it be, aspiration and they're vomiting, or that we're going to have to deal with? And everybody sort of weighed in like, I think it's maybe a 20% risk or a 10% risk or a 30% risk. And, eventually we decided, okay, you know what? I'm not okay with those percents that people were kind of kicking around. And I had agreed with most of them. And, we proceeded with intubation. And in hindsight, it ended up, he did have some head injuries in addition to alcohol, but that's sort of a hindsight bias. And what was, probably most important was that we kind of came together and made a decision, and we added in, as it was not a single element, it was multifactorial. So things that really weigh for me is obviously hemodynamic stability. Obviously, is there a dynamic airway, which we've talked about? Is there critical hypoxia? Sure, those things I think most of us are pretty accustomed to. I think there's the idea of what other injuries are they likely to have. Patients with like a significant amputation, sometimes you just can't manage their pain. And the humane thing to do is intubate them, so that now you can do things that you can manage their orthopedic injuries and proceed, because that they're going to need a pretty urgent OR. Some degree of patient cooperation. And sometimes it's just a conglomeration of multiple factors that will then sway you one way or another to either decide to proceed or, like George said, I love this idea, like most of the time you do not need to rush in to make this decision. And by rush, I don't mean, it's not like you're going to sit around for an hour. But you don't need to kind of go ahead and make the decision within 3 minutes, unless you simply cannot oxygenate this patient. If they're oxygen 60, despite all of your conservative efforts, sure, there's going to have to be some action. But beyond that, like most of the time we can kind of look to our colleagues who are around us, get some opinion, and then you as the leader ultimately still take action. But I think that we have options often. There's no sort of recipe or kind of cookbook here. This requires sort of thoughtful reflection as well every time you intubate or choose not to intubate with a patient, and decide, what were the factors that led you one way or another. You sort of try and improve every time.
Dr. Kovacs?
Acute airway loss, right? The patient who has an obstructed airway, and not obstructed because they swallowed a frog, but obstructed because they lost their tone, and you need to open their airway and oxygenate and ventilate. That's number one. That's a do now. The majority of patients that we intubate are because of correction. So correction essentially in the context of some form of respiratory failure, and most of the time it's hypoxemic respiratory failure for whatever the cause. The third one is airway protection. We've talked about the timing of that, and the fact that there's no clear cutoff of a number. It's looking at the context of that scenario. What's the risk of the procedure versus waiting and not doing anything? And the last one is prediction of any of the above, right? So I predict that this is going to happen, and those are the indications that from our point of view, I think that are reasonable to consider. Getting onto the question about when, I can quote literature from pre-hospital intubation saves lives, pre-hospital intubation in the context of trauma kills patients, that management in the emergency department versus the OR, it's better to wait and manage them in the OR. A procedure is never going to trump context, or a device is never going to trump that context. But the one I want to get back to is a study by Davis back in 2005. They were looking at pre-hospital medics, teaching them how to do or employ RSI for head injured patients, and looking at success and outcomes. And there's a graphic, and I'll share that graphic with you. And that's of a scenario of a patient with a head injury. Their saturations are 100% when it begins. And they had objective data for all of this. This is not just memory. They actually had tracings for all of this. During the intubation attempt, the SATs fall to less than 80. And then subsequent to that, their CO2 drops to less than 20. And I'm going to guarantee you that when they get back to the wherever they were afterwards, there's high fives, right? First attempt success. But those two transient events have doubled this patient's mortality. And that won't be realized in the resuscitation bay. But when you follow them through, that's what you see. So again, it's that caution. How could have this been avoided? It could have been avoided from the point of view if they had appropriate monitors, which is waveform capnography throughout. But what's our response to an episode of hypoxemia is that we have to bag that patient like crazy. And I walk in there and you see people and they're bagging at somebody's heart rate. And you look up on the monitor and the CO2 is 6. Right. And, that's not helpful. Right. You've got little tiny cerebral vessels right now that are, under perfusing that damaged brain. The physiologically difficult airway in the context of trauma, it's been around for a very long time before we coined the phrase. And we need to pay attention. If you would have just put the patient on oxygen and transported them and managed them, they would have had better outcomes.
We're going to dive a little bit deeper into the isolated head injury patient and airway considerations with the isolated head injury patient. But I think we can sum up what we've said so far in what Dr. Kovacs just said, and I'll quote him here, is the procedure should never trump context. I mean, that pretty much says it all right there. Beautiful. So the indications for intubation in the polytrauma patient are not simple. They're multifactorial. We know that the old rule of GCS of 8 intubate has been disproven, and it sounds like the more experience you get in trauma, the less aggressive you are about intubating, and your indications are kind of not quite as aggressive. Some of the factors to consider that we've mentioned so far are hemodynamic stability, critical airway compromise, intractable pain. You have to consider patient cooperation. You have to consider other injuries that are likely to be involved. And then also airway protection, their chance of aspirating, for example. So it's really weighing all these factors in the individual patient. So not as simple as I hoped you guys would be able to tell me. As of the day of the publication of this very podcast, there are only 10 days. That's right, 10 sleeps until the 2024 Online International EM Cases Summit. Right now is your last chance to register for the summit so that you can devour this peak medical education experience. It's the very best that EM Cases has to offer, and at the same time, it'll rejuvenate your EM practice by all the interactions you'll have with EM providers from all over the world. There's 30 world-class speakers, 3 symposiums to choose from, small group simulations, a free ebook summarizing the talks, 3 months access to streaming the talks, and an opportunity to ask any burning question you have to any of the 30 speakers. The Summit team has spent more than a year preparing for this big event. We're really hoping you can join us. Head over to emcasessummit.com before it's too late so that you can register and join us. I want to move on to penetrating anterior neck trauma, and that's a scary situation. In the case I presented at the top of the episode, I think it's safe to say that everyone taking care of that patient, of the woman who got the knife plunged into her neck, is going to develop at least a little bit of tachycardia. So let's dive into that case a bit more. First, I described an entry wound to the anterior of the neck just off the midline, which would be zone 2 of the 3 zones of the neck. I understand there's been recent literature on this and a recent sort of change in approach in terms of the zones of the neck. Dr. Kovacs, how useful is the 3 zones categorization in predicting the injury pattern or severity of one of these kind of penetrating neck injuries?
The only time I talk about zones of the neck when I'm trying to quiz somebody on their anatomy. My view on the neck is it's a small space through which a lot of important things pass. And if you have a hole in it, in general, it's bad. Whether it's declarable now, right? If it's declarable now, they're going to die unless you do something. Or it has, as Andrew's going to talk about, again, hard signs versus soft signs. But the zones talk about the entry. And where it's been, people are calling into question the zones is that the entry is important, but trajectory and pathway is a completely different scenario. So it begins in zone whatever, might be in another zone, depending on what it was, how long it was, what direction it's going in, right? And then what symptoms that they have. So it's all about dynamic change and what symptoms they have. So in terms of their airway, if they're able to speak, is their speech altered? Do they have upper airway sounds? Whether it's a gurgle, stridor. A stridor is just a sound acutely people make before they die. Any sounds, gurgling, seeing bubble, what's the trouble? It's bad.
Anton, you have to put that in the show notes. The bubble, what's the trouble? I mean, honestly, that is like it.
We've got two amazing quotes already. Bubble, what's the trouble? And procedure should never trump context.
Are they dyspneic? And dyspnea is a really important thing because it's the subjective sensation that, wow, I'm having trouble breathing. And I've done endoscopies on patients that come in with that, and I respect noise and I respect dyspnea and that they're having trouble, even though the respiratory rate might be okay. So those are features that get my sphincter tone up. I mean, if you see an expanding hematoma that's visible, if there's subcutaneous emphysema, these are all features that sort of speak for themselves. But if you take this back and reference the point that people say it's safe to do an RSI in patient with a penetrating neck injury, absolutely it is. If somebody's got a hole in their neck and nothing else is involved, do whatever you want. And so if the prevalence of something significant is less than, let's say, 3%, then 97% of the time, you're fine. Because they don't have an injury to their airway or a distorting anything. I'm not worried about somebody with a hole in their neck. I'm worried with a hole in the neck, and they're maintaining it with their tone. They're maintaining it because they don't have positive pressure ventilation, other things that are gonna potentially go awry if you don't consider it. You can have a persistent air leak from a pneumothorax, and yes, you have to manage that too. That can present with neck subcutaneous emphysema, but it's an airway injury. Just at what level? It's the level of the lower lung, the trachea, or the upper airway. All of these things, you run into problems if you don't recognize that and think about it and manage it beforehand if possible.
All right, I want to zero in there on the so-called hard signs and soft signs. Let's just hammer out that list. So, Dr. Petrosoniak, what are sort of the hard signs, and why do we differentiate between hard signs and soft signs? What are some of the soft signs? How is it helping us in our decision-making at the bedside?
I'll be honest, this is actually something that needs to be in your head. It needs to be memorized to some degree. It doesn't mean that you have to remember every single one, but to George's point, this is not about remembering the zones of the neck. This is about deciding, should this patient go immediately or very soon to an operating room, or can we image their neck to decide on subsequent management? And so I'm not big on memory. Like, there's a reason why we all have smartphones, and probably ChatGPT will be intubating for us in a few years. But this is something that is just like remembering the dose of epinephrine. If you take care of trauma patients, or can be potentially taking care of trauma patients, you do need to know the things that you are looking for in the first 30 seconds that somebody with a penetrating neck injury rolls in. Because these are the patients that can come in talking, kind of, and then die in front of you. And it's a catastrophe. And so you do need to be able to at least acknowledge when there's some real risk to the patient. So the hard signs traditionally are listed as, refractory shock. I'm not sure exactly what to do with that one, but sure. I mean, it's on the list, and yeah, you should look for other, sources of why they have, profound hypotension. But could it be from the neck? That's where they sort of want you to go and check and see if that's a possibility. But the big ones are, severe or pulsatile hemorrhage, a large or expanding hematoma, so obviously if you see it spurting out versus, there's a hematoma that's expanding under the skin. Most of us aren't listening for bruits. My stethoscope hasn't really been allowed in the trauma bay for a long time. But nonetheless, you can listen, an audible bruit or a thrill that you can palpate. And then those are sort of the vascular elements or the vascular components of hard signs. And then the aerodigestive ones where you have obvious airway compromise or stridor, wound is bubbling, there's significant subcutaneous emphysema. And, you should look and see, like, is this coming from the lungs rather than from the neck? But the default is it's not unreasonable just to assume it's coming from the neck if you have a penetrating neck injury there. And then hematemesis, the patient opens their mouth, there's blood in the oral pharynx, and or like massive hemoptysis. And so those are the typical hard signs in addition to obvious neurologic deficits. Those are the ones that you should really be paying attention to when they come in. And then there are soft signs, and we can those are basically just a dulled down version of what I just described. So a small stable hematoma, a history of bleeding, or a hematoma that expanded but is no longer. You had transient hypotension. There's something looks like an active venous ooze or a non-arterial bleed. You might have some painful swallowing, odynophagia or dysphagia, or some subtle changes in the voice. Or, there was a report of hemoptysis or hematemesis. And those are the soft signs. What I would say, and I think George would probably agree, there are patients who come in with what looks like a stable hematoma in the neck, and you blink and suddenly it's expanding because they coughed, because you shook the bed, because you clapped twice and jumped up and down. Who knows why? But suddenly that soft sign becomes a hard sign. And so, I might be still willing to take a patient with soft signs to the CT scanner because they've demonstrated stability over a period of time, 10, 15, 20, 30 minutes in the trauma bay. I don't dismiss the potential risks that those patients have, because I can think of probably 3 or 4 cases in the last year where a patient came in with, quote, a soft sign, and within 20 minutes, we were intubating them, and we're watching an obvious expanding hematoma, and we're losing an airway in real time. And so, yes, hard sign, like that should very much make you concerned. A soft sign, don't think that you're out of the woods, because that might very well change. But the first question you ask when you see these patients, do they have hard signs or not? If they have hard signs, it's OR. If they don't, then likely you're going to be going to a CT scan, and then eventually either to an OR or not, to decide.
Okay, so just to clarify there, hard signs, you need a procedure, probably in the OR. Soft signs means you need imaging, CT. And that, just to emphasize there, that this is a dynamic thing. So they could have a not worrisome soft sign 1 minute, and then the next minute it turns into a hard sign. And so repeated assessments are vital in this. In penetrating neck trauma, I've been taught to try to avoid positive pressure ventilation from above. So no BVM, no supraglottic airway. You're not bagging the patient like crazy from above. Could you just explain to our listeners why you want to avoid positive pressure ventilation from above in the patient with a suspected or potential neck airway injury?
Yeah, and it's a broad statement. Positive pressure ventilation creates all kinds of problems, whether it's related to penetrating neck injury or just the fact that we're increasing intrathoracic pressure and somebody's depleted because of hemorrhage, and because we're creating a positive pressure, almost obstructive shock scenario too. So these are all things that you do need to think about in general. So when we transition somebody to that by doing an RSI, there are all kinds of physiologic consequences that come with that transition, but specifically relating to a hole in the neck that has affected the airway in one of those locations. You can be in a scenario where you're bagging the patient, and now you've got what was just subtle or no evidence of subcutaneous emphysema. There's something that is the picture of the Michelin Man. And that is a disastrous scenario. So what that means is that their head and neck is just full of air. and makes everything potentially impossible, from accessing the mouth to doing a surgical airway. So you may know that in advance. And what you do is you provide what they need. And most patients here, if they've got a pulmonary contusion or something else, they might require some pressure support. But most of the time, they just need oxygen. So use oxygen with nasal prongs underneath and a non-rebreather, and then escalate that only if it's required. And the time where that becomes required or has become a fairly common routine is during what's called phase 2 of an RSI. So phase 1 is your pre-oxygenation. Phase 2 is your induction time. Phase 3 is your apneic oxygenation. So phase 2 is when you're waiting for your drugs to work before you go in with your blade. And most of us now are doing what we refer to as gentilation during that period of time. And with gentilation, the only way you can do that, and that was Max Sorbello from Italy and Ross Hoffmeyer from South Africa coined that term. And you're doing it guided by waveform capnography, seeing that you've got a good seal and that you've got a pressure manometer, and you're gently assisting that patient up, blindly squeezing the bag and getting into trouble in that scenario. But that's what we will often do during that induction period. As you have somebody who's doing fine, and all of a sudden during that period of time, because you feel you need it to support what pre-oxygenation techniques you do, then you convert that normal non-distorted airway into what's an impossible airway. So yeah, positive pressure ventilation, and somebody's got a hole in their airway, can end up in the wrong place and cause all kinds of problems.
One question that seems to come up frequently is about C-spine immobilization. For patients with blunt trauma, we need to maintain manual inline C-spine immobilization throughout our airway management. Dr. Petrosoniak, for penetrating neck trauma patients, do we need to worry about immobilization of the C-spine? I mean, this can interfere with our ability to intubate. We'd all prefer never to need to use inline C-spine immobilization. It uses another team member. It just makes things a bit more complicated. Can we get away with not doing inline immobilization for our intubations for penetrating neck trauma?
I mean, the vast majority of the cases that I manage that have penetrating neck injuries, we're not maintaining C-spine precautions because there's no evidence to suggest that there's a C-spine injury. You know, if a stab wound to the anterior neck, you'd have to imagine that that knife hits the cord kind of through the vertebral bodies, and you now have some injury there that then manipulation is going to make it worse. This just doesn't follow any logical sense. So the short answer is, in the vast majority of cases, there's no role for C-spine immobilization. Even if you're trying to maintain C-spine immobilization, let's say you decide for whatever reason that you think that it's appropriate, ultimately, you get to a point in an intubation procedure and you're having difficulty because you've done that. You may have to relax that immobilization because it's far more important that you have, a patient without profound hypoxia than it is to maintain C-spine immobilization and have them arrest from a hypoxic event. And the vast majority of the time, I'll find that the neck collar is placed actually often by EMS, sometimes to just provide, because they don't have enough hands, to actually just provide tamponade on a bleeding wound. So it's not a bad idea to have there, but I will ask them, why was it applied? And 90% of the time they tell me it's because there's only 2 of us in the truck and we just didn't have enough hands to be able to manage all of this. And they'll have put down the collar so that they could apply some direct pressure to the area, which is pretty reasonable. So then when I'm removing it, I don't just go blindly removing it. I have a plan to actually then manage a potentially, a hard sign there if I think there's an expanding hematoma. In a patient with a GSW trajectory that's transcervical and there's obvious neuro deficits, I might do my best not to manipulate this patient's neck. But again, the priority is to still get an airway. And so I will call out to the team and say, listen, we're going to do our very best to minimize the movement of this patient's neck during intubation. But it's not going to be at the expense of getting the airway, because this patient will do far better with an airway that's definitive in place than me moving the neck and unlikely going to be causing substantial harm during the intubation. And there's some recommendations out there, I think, out of the pre-hospital space, and we can provide that in the show notes, but a pretty strong recommendation against spinal immobilization of patients with isolated penetrating trauma. and the use of a pretty weak recommendation for rigid collars. So by and large, I'm not using these in most of these patients. I'm not maintaining C-spine immobilization unless there's some extraordinary circumstance that would sort of move me towards this, maybe concomitant blunt injury, and I think that they fell off a roof, and then I'm worried that they actually might have a C-spine injury. Okay, then I might be convinced. But by and large, no.
So it's critically important to prioritize oxygenation, ventilation, maintaining physiologic homeostasis. And if you review the literature, even with patients with a known cord injury that are going to get worse because of airway management, there really is no significant supporting evidence. And I'm going to refer you to a document from the Difficult Airway Society in the UK, critical care, neuro anesthesia, and some representation from the Royal College of Emergency Medicine came up with recommendations for airway management in patients with trauma and potential C-spine injury. And in their recommendations, you'll look at all of them, and everyone says weak recommendation.
And now a word from one of our sponsors, Easy Resus, the resuscitation assistant. Easy Resus is thrilled to announce that they are now available for institutional access. In addition to providing the app for all employees in your organization, this means access to exclusive features like printable protocols with calculated medication doses, customizable content to fit your local protocols and practices, access to Easy Resus on computers via the web-based version, and much, much more. To learn more, visit the institutional license section at easyresus.com. And as always, you can download Easy Resus and use the promo code EMCASES, that's EMCASES, one word, to get your 2-month free trial on an individual subscription. Okay, we've covered a ton of stuff already. Everything from the timing and indications of intubation in the polytrauma patient, clinical clues to penetrating neck trauma badness, why we should avoid positive pressure ventilation from above in the penetrating neck trauma patient, C-spine immobilization, lots of pearls and pitfalls to think about. I want to get back to the case that we opened up the podcast with. Dr. Petrosoniak, could you kind of put it all together for us and describe your approach to penetrating neck trauma airway management, like in this 25-year-old woman who got stabbed in the neck and came in gurgling with a SAT of 90%.
Yes, I'm going to try and kind of break this down into 4 key areas. Ideally, you get a little bit of heads up. You may not. If you don't, you're still going to need an opportunity to very quickly prepare your team because things need to happen and you're going to be managing the patient. And this could be you and a nurse because you're in a small center or in a large trauma team. But there has to be a prep opportunity, even for 30 seconds. Ideally, 2-3 minutes if you get a heads up from EMS. But I will declare out loud that if this is what I hear and I have a patient with SATs of 90% and an obvious penetrating neck injury, I'm going to tell people out loud that I'm very concerned that this is a critical injury that can result in, a very bad outcome for this patient, and that we all need to be dialed in over the next 10, 15, 30 minutes of this patient's care. And that if there's anything that is seen that somebody feels uncomfortable with, that they notice that there's an oxygen drop or that the patient develops a more expanding hematoma or I need everybody to be watching, and I'll kind of list out those things so that there's a clear understanding of the critical nature of this patient. And I'm going to say it out loud. And I'm going to say that we could lose this airway and that we will need to have some plans in place, an A plan, a B plan, a C plan, perhaps a D plan. When the patient rolls in, if I'm team lead, I'm taking it upon myself to briefly examine this patient. Even when I have other people that can do this and that are tasked with this, as the team lead, I need to see this myself because I need to be able to understand what's going to happen. I can't rely on somebody verbally just giving me feedback. Oh, there's a little bit of blood in the airway. I have no idea what that means. I need to see this myself so that I can then better make a decision on the cadence of the resuscitation and the decisions by which I need to undertake. And so I will move myself to the head of the bed And I'm going to be looking for those hard signs that we just talked about. That is number one, because that's going to really dictate the subsequent care for this patient. The other thing that's going to happen is there's a penetrating neck injury. I have a rule when patients come in with penetrating injuries, I need to see their back, and it needs to happen immediately. Because if we decide this patient has a penetrating neck injury and we decide to go ahead with intubation at some point, and I miss the fact that there's a stab wound to their back, to their posterior thorax, and suddenly they have a cardiac arrest because, well, I don't know why, because I didn't know that they had a tension pneumothorax. That's on me. And so the minute that a patient lies flat in a trauma bay, my experience has been you lose that back for about 10, 15 minutes. And so I need to see that right away. Quick log roll, whatever it might be. If they're able to sit up, I just have them put their hands in the air, look in the axilla, and check the back. The groin we can get to, and that we can, address later on, but I need to see the back. And then I'm going to complete, my exam, and then we're moving to a preparation phase. And that preparation phase, I think we'll get into the details of exactly what we're going to have here, but there's going to be a preparation of a suite of airway options, as well as medications, as well as blood products, and then subsequent plans for post-intubation care. Because it's very clear that this patient is going to be, I'd say probably 95, 99, probably 99%. I'm not sure that there's any actual percent that we're not going to intubate this patient. As I'm conducting this brief examination, there's a preparation phase. And then I'm going to move into initiating the plan and executing the plan of this phase, which will be intubation, subsequent or simultaneous hemodynamic management, and then a decision. At this point, all things are pointing towards operative management rather than an OR. That's kind of how I see this as a preparation. There's a very brief exam. Simultaneous to that, I'm going to be calling out for the team to prepare in the moment, and then we're going to initiate and execute the plan. So sort of 4 phases.
Fantastic. That's a beautiful way to think about preparing your team, what's important on the exam, those hard signs. That pearl I love about having always look at the back so you don't miss a tension pneumothorax, your gear and meds, and then executing that plan to intubate and resuscitate. Let's talk a little bit more in detail about the intubate part. So, Dr. Kovacs, assuming that you agree with Dr. Petrosoniak about the plan, the gear, brief exam, let's zero in on this 25-year-old woman who has this penetrating neck injury. She's gurgling and the SAT is 90. What's your airway strategy going to be?
Whether you're in a regional center or you're in a small center, calling for help doesn't necessarily mean that you're going to have an ENT at your bedside in 10 minutes, 15 minutes, a half hour. It could mean that you know that there's a colleague in your town who's more experienced, who lives around the corner, that you're going to get on the phone and say, listen, I hear this person's coming in. Can you come in? It means that you're going to ask the crew to stay behind and get their extra hands based on that context. It means that you're going to, if you have time, get on the phone and communicate. And this is critically important. When you say, hey, listen, I'm just calling you to give you the heads up, don't use that kind of language. We've got a really sick patient. Sounds like they got a hole in the neck. I might need some extra skills. I've got equipment down here. Can you come to the ED now? Because they're going to say, oh, yeah, thanks for the heads up. When they come, just give us a call. Be very specific on the language. You need to articulate this. And this is not a place for egos. So let's talk about how we might manage this person's airway. If they are obtunded and in shock, they are going to die. And anything you do to rescue them is a big bonus here. And I'm not being cynical. I'm just sort of saying is that you do whatever you need to do. So when I say we're going to avoid positive pressure ventilation, well, if they're not ventilating, I've got to do what I've got to do. I've got to manage. I've got to oxygenate them to give me time to get in there. And whoever's going to be there in terms of using a laryngoscope and a tracheal tube has to be the most experienced person in the room. So if they're going to die, you're going to push drugs and try to get in there using a small tracheal tube, having backup tubes that are smaller, being careful to not go in and push too far, being gentle with what you do and doing what we refer to as gentiloscopy and gentilation during it and securing that tube. And if you fail, then you're going to go to the front of the neck and cut to air if you fail from doing it above. So that's the crashing patient who comes in. I've had plenty of these patients, though. They come in, they've got a hole in their neck, and they have these hard signs, and they're talking. Their voice might be abnormal, et cetera. And as Andrew said, they need to have their airway managed before they go to CT. And so the best anxiolysis for a patient in distress is your voice and their trust in you. And Laura Duggan said this too, is that your calm approach is worth 2 milligrams of midazolam. And I do this, when I do an awake intubation, and there's probably no one else who does more in Emerge. 10% of our ED intubations are done awake, but it's all about that, about having that communication. I'll sit on the bed with them. I said, "You're looking at me. I'm here to look after you. I know that things are bad. We're going to give you stuff for the pain, and what we have to do is put a breathing tube in. But I'm going to talk you through all that." And I'm having that conversation. And then I've got the luxury of having people in the room that share my mental model. The medics and the critical care people, they're already setting up the scope. They're already setting up, they've got their ketamine and rock. They've got the VL device, hyperangulated blade. They've got a Parker, 7 tube and some smaller ones. And that's all happening. But they also have the flexible scope in there with all the topical gear, because this part is going to take time. And I'm okay with a SAT of 90. I mean, I never got 90s in school. 90's good. If it's 90s and falling, then I'm worried. And so I still have to take time here. And my preferred approach is this person have an awake intubation. Now, it doesn't necessarily mean that it's going to be done by me and in the ED. It could be that the best situation is that this happens in the OR. All of this happens in the OR because, your colleagues, that's a more familiar environment. And if they're going to need to do a front of neck airway, it's going to be a trach. And because of this and the level of the injury, and for them to feel comfortable in that environment with the equipment that they have. So if I've got that ability to transition them and everybody's ready, then I might just sort of say, this patient's sitting up in whatever position the hell they want. They've got oxygen on. They might have a milligram of Versed just to help them chill. I'm talking with the team. We're talking about what's the best way to do this. If the answer is to do it awake, but the fallback is that you're going to have to do a front of neck trach, that's probably best done in the OR. The principle is you'd like to breach with your scope the area of potential injury, and then subsequently put the tube down over it. Because any sort of passage proximal to that has the potential of it going into a false passage. And remember, RSI, rock uranium, has all kinds of hemodynamic consequence, not because of the agent that it has, but the fact that you're transitioning to positive pressure ventilation, that you have to, bag these patients. They lose tone. And right now, if you feel your larynx with tone, you grab your larynx and you feel it move side to side, it doesn't move much. But as soon as you're relaxed, it moves a ton. And if you've got a hematoma that was contained by those muscles that are now relaxed, now it's a distorted airway. And so all of these things you sort of need to consider. And there's going to be failed awakes that you're going to have to back up and sort of say, I'm going to go on and do an RSI. And this is where the term DSI gets used. And I love Scott and I love the term. But the problem I have with DSI, it doesn't mean that I'm going to sequence and intubate them. It means I'm doing facilitated cooperation for whatever the hell it is, so that I can oxygenate that patient, so I can manage their pain, right? Or whatever I'm doing. And then I might go on and finish it with some paralytic and intubate that patient, or I might not. And I'd say about 30 to 50% of the time, I can't just do it topically. I have to do it topically with some analgesic dose ketamine. And what you'll find is that the sicker patients dissociate at much smaller doses. And it's just sort of an experience thing. You'll give somebody an analgesic dose and they've got nystagmus, right? And I think it's just, related to, the way the brain's impaired in that scenario or whatever it is. So that would be my desired approach, is to do this person awake, traverse the area of potential injury with the scope, and then pass the tube. If they're crashing and they're about to die, just RSI them, make a large midline, rescue FONA if you need to, cut to air, ideally go through structures that you know. If they come in talking, make sure it's somebody who's experienced, and ideally manage them with a flexible scope.
Got it. Okay, so just to review there, first, get help and don't do it. Please, can you kind of help me really get their butt down there to help and use the right language? For the crash situation, your plan A is RSI, plan B is front of neck. In the non-crash situation, your preferred approach is awake with the scope, either by you or in the OR. And if that fails, again, front of neck. Dr. Petrosoniak?
The one thing I guess I would add, I will use, with the fiber optic, I'll use a video scope so that you can bypass the injury with the fiber optic. Often, and you can do that. You want to be able to see how you're going to be able to get that tube through the glottic inlet, and that can be done with an additional video laryngoscope. You have a video laryngoscope, and then you use a fiber optic, which also has a screen, so you can see, on one screen you're looking at carina, on the other screen you're looking at the intraoral cavity, and you're looking at the cords, so that as you're passing that tube, once you're ready, you're able to navigate the nuances of getting it through the cords.
Yeah, I agree 100%. Refer to this actually as a triple setup.
It's the triple, right? I mean, as an ode to Tim Hortons. No double here. It's the triple, right?
Do you dread doing your clinical notes every shift? Do you feel like you can never get ahead of charting? If you're shaking your head yes, keep listening. Freed is an AI scribe that listens, transcribes, and writes medical documentation for you. Notes are written in your style and ready the moment the patient encounter is over. Just imagine leaving work at the same time as your last patient. Freed is HIPAA compliant, secure, and takes less than 30 seconds to learn. Artificial intelligence can't replace you, but it can do the administrative work that no human should be subjected to. All the magic happens in just a few clicks so that you can spend less energy on charting and more time on doing what you do best. Freed learns your style over time, just like a human scribe, and it'll never quit on you. More than 6,000 of your clinician colleagues already use Freed AI. Get back to spending your clinical time caring for patients and let Freed AI do the rest. Head over to getfreed.ai and use the code EMC50 to receive $50 off your first month with Freed. That's getfreed.ai with the code EMC50. So essentially, if you don't have a flexible scope in your ED, get one. And if you don't have the training for a flexible scope, get the training, is the bottom line here. Because if you are faced with a penetrating neck trauma patient and there's no one else around to help you, you need these skills. I wanted to just zero in on one detail, and that is patient positioning. From the time that they actually roll in to the time that you're actually doing your airway management. In the old days, we would, as soon as the patient rolled in, we would just take them right down into the supine position, and there's all kinds of problems associated with that. Dr. Kovacs, can you comment on positioning of patient from the time that they roll into the emergency department, and specifically with a patient with an anterior neck injury?
Again, referencing Rich Levitan, he refers to supine position as the coffin position. We snore when we're supine. The anatomy works against you from just structures falling posteriorly, offloading diaphragm, It's not a position for airway management. And even a patient in shock, if you say, well, they're in shock, you're going to put them down. I said, I can make their blood pressure higher. That's not a problem. I've got drugs and other things I can do. I'm going to have them in at least a reverse Trendelenburg, if not, a sitting position, regardless of what's going on. And especially anybody with an upper airway anything, they're not going to want to be in that position. So they don't want to be in it for a reason. And that reason also could be is that they've got other injuries and they've got blood back there. So sit them up. That's the position of comfort for their injuries. It's the position of comfort for managing the airway and ideally throughout the process, have them sitting up.
Yeah, Dr. Kovacs has some great videos on awake intubation, and he stands in a very different position than we normally intubate people. So I do encourage people to watch those videos of the technique of awake intubation and where you're standing relative to the sitting patient. I want to move on and throw another curveball into the situation here and talk about the contaminated or soiled airway. It's not uncommon for a trauma patient to vomit. We talked about this a bit in our hemoptysis episode. Dr. Kovacs, how do you approach the soiled airway in the trauma patient in particular?
First, I avoid soiling myself. So that's all about preparation. And so tonsillar suction, Yankauer suction, was meant for suctioning oozing from bleeding. It was never designed for managing volume. And there's two types of volume: blood, or it's chunky stuff. And both of them, depending on the rate with which it's coming from, whether it's coming from a maxillofacial injury and coming down, or whether it's coming from an injury below and coming up, you need to be able to manage that. Everybody's heard of SALAD, and I think we'll refer to material that you'll have in the show notes to go over that. But the principle is have two devices there, preferably two decanto suctions by default to manage that volume. The only thing you need to be careful of is that it will suction everything, including oxygen. So if you're in the mouth with the decanto suction going full steam, it will also suction all of that oxygen that you are delivering. So just something to be aware of, and it's why I don't like leading with the suction. I understand the principle, right, to create a clear space through which to move, and you need to do that. But be careful about some downsides, and that's one of the downsides. So
I suppose not leaving the suction in there for any longer than you need it.
Yeah, use it as you need it. Make sure you have two that are available to it. As you know, if it's higher volume, again, just putting it in the esophagus, moving it to the left of your hand that's holding the laryngoscope, and then going in with a second one, clearing the airway, and then if it's still an issue, leaving the decanto suction in, and you can actually put a bougie through it and remove it. Majority of times you don't have to do that. You just have to use appropriate suction and using a decanto, and that's going to clear your large volume, but knowing that there's an alternative way. The biggest reason why people vomit is people go in too early with a blade. If you're doing an RSI, this drives me nuts. So there was two studies. One was published in JAMA, and it should have never been published. And it was comparing rocuronium to succinylcholine in terms of first pass success. There can't be a difference. As long as you're waiting for those two drugs to work, it's a binary. You're waiting to work, you're paralyzed or not. There cannot be a difference. Other than the reason why they found it, another one published in Annals way back when, is that because people don't wait the appropriate time and they go in 30 seconds. And so then really it has to do everything to do with what induction drug that you're using. So if you're going to use the drugs, then wait in doing it. The most common cause of vomiting in a patient, because succinylcholine and rocuronium is the greatest antiemetic you have. Right? They are not going to actively vomit in this scenario. The real reason is people are going in too early, and then the patient, isn't topicalized, and then they're going to actively vomit. right? So that's the preventative measures are the best.
Excellent. So don't stick the tube in before the patient's paralyzed because they'll vomit and then you'll have a soiled airway on your hands. If you can get your hands on decanto catheters, get 2 of them. You need 2 of them for the patient. And just remember that you're sucking out oxygen as well. So you want to use the decanto catheters as little as possible, just enough to be able to get that airway secured. You had mentioned airway medications. You touched a little bit on rocuronium and ketamine, but I want to talk specifically about the patient who's shocky that you do decide to do an RSI on. And there's just one question I have about your dosing of ketamine and rock, because my understanding is that the recent literature suggests that lowering the induction dose of ketamine to, say, 25 or 50 milligrams in the catecholamine depleted patient actually does not prevent them from crashing. For so long we were giving really sick patients really high doses of ketamine. We saw them crashing. We go, we better lower the dose. So then we started giving like 25 or 50. And I've had patients before that I give 25 or 50 and they still crash. And now the evidence is saying that there's actually no evidence that decreasing the dose like that will prevent them from crashing. So I've gotten a bit confused about the best dosing for ketamine and rocuronium for that matter in these really sick patients. What's your opinion on dosing for RSI meds?
If you want to find a paper that shows ketamine's better than etomidate, you'll find that. You'll find a paper for etomidate's better than ketamine. You're going to find a paper that low dose is better than full dose. You'll find all of this, and it really gets back to, and this is a term that Scott Weingart referred to, and there's a large trial called the Intube study. I have to talk about in a second, but the propofol assassins, right? Is that we know that if you use OR doses of big white, followed by your rock badness is going to happen, but this all really gets back to resuscitating before you intubate, about taking the time. So you can lower your dose of ketamine, right, to whatever. But if you haven't properly, managed this patient in terms of giving them blood, of splinting their pelvis, of yes, even starting norepinephrine after you've done all of these things, if their shock index is greater than 1, then badness is going to happen. And it gets back to the fact that rocuronium has hemodynamic consequence, not because it causes dilation of anything, right? It's just because it forces you to suddenly transition to positive pressure ventilation, which is going to decrease your venous return. It's going to, increase the workload of your RV, and all of this in combination with a patient that's hypoxemic and other factors. These patients do crash. But I think the principle is still there, is minimize, your induction drug. And some people say, well, listen, if the person's circling the drain in that situation, and heaven forbid, but give rocuronium as your only agent. Now, I can never sort of say that without, I'm sure there's people if I was on the Twitter, that would be just demolishing me right now for that. But again, Scott referred to this. What's the greatest risk to this patient? Using an amnestic dose of Versed and following rock might be the appropriate thing to do that. But the general principle is still to give an induction, be mindful of that, and use a bigger dose of your rocuronium. And I don't work in 0.2s or whatever, so none of us do, right? You're going to look at them and you're going to give roughly 1.5 to everybody. It's a binary drug. You want it to work quickly. Everything is easier in airway management in a paralyzed patient, mass ventilation, supraglottic airway, laryngoscopy, performing a crike. So controlling it. Last crike I did actually was on a trauma patient. It came in, was in shock, and GCS3. GCS3 presumes, we should be able to just put a tube in. And GCS3, and we've all seen patients wake up during, cardiac arrest. Not wake up, but, move towards you. And so a lot of these patients have clenched teeth, and I gave them 200 of rock. And they still didn't resolve their clenched teeth, and so I moved to the neck and did a crike. So principle is that try not to make them worse by altering physiologic homeostasis with the induction drug, recognizing the problems with those induction drugs, and recognizing that transition to positive pressure ventilation has consequence, and use big dose of your paralytic.
I mean, I don't think we have overwhelming evidence that the contrary of giving larger doses of induction agents, ketamine, etomidate, whatever, is going to help this patient. So I think like being as judicious as possible is still, you can always give a little bit more if you need to. When you're talking about the induction agent, obviously the paralytic needs to get in, and in a reasonable dose, maybe larger than you might typically give. But I'm not in a position where I'm giving, 1 or 2 per kilo of ketamine in a sick trauma patient. I just don't see the upside there. I can imagine there's downside. And like George said, somebody will publish some observational trial and somehow one will look at an association-based level data rather than any causality, will make some claims. So for me, I'm still very cautious with the doses that I use. If you're sick, you get less. If you're not sick at all, you can get a normal dose.
Yeah, so I think there is a role for DSI here. And there is some literature that's come out beyond the original work that Scott did, and doing it as a targeted endpoint. And the targeted endpoint that I'm going to look for is at the bedside, recognizing I've given 10 milligrams to somebody and they've been dissociated, right? Is looking at their eyes and the nystagmus, right? And titrating that dose to effect, minimizing and monitoring their blood pressure. And then once they're in that zone, then finishing it with that. So not committing to a low dose of 25% or 50%, but a titrated dose to effect. And this titration's happening fairly quickly.
I do think titration and an accelerated DSI approach here, dictated by the patient's hemodynamics, is very reasonable.
All right, great. So generally speaking, start low and go slow with ketamine, for example. Go big with rock. And DSI certainly is an option in some of these patients. This episode is sponsored by BetterHelp. Giving thanks is great for everyone, like simply taking a moment to thank someone in your life. This month is all about gratitude. And I'm not only talking about gratitude for others, but there's also value in feeling some gratitude for ourselves in this ever-changing world we live in. And giving yourself some kudos, for many of us, can be difficult. This is where talk therapy can be really beneficial by learning positive coping skills and how to set boundaries. Therapy empowers you to be the best version of yourself, regardless of whether you've experienced any major psychological trauma or not. If you're thinking of starting therapy, give BetterHelp a try. They make it easy, efficient, and convenient to get matched with a licensed therapist. Let the gratitude flow with BetterHelp. Visit betterhelp.com/emcases today to get 10% off your first month. That's BetterHelp, HELP.com/emcases. Let's get into the different kinds of trauma patients and how they might alter your airway strategy. We've already talked about the contaminated or soiled airway. I want to cover head injury, which we've touched on a little bit, but I want to kind of clarify exactly what to do for airway management in the head injured patient, the agitated patient, which often an overlap between those two, and then the facial smash patient. So first up is the head injured patient. So Dr. Petrosoniak, how should we adjust our airway strategy in, say, the patient who went swimming, they dove into a lake, a nice Canadian freshwater lake, and they very unfortunately smashed their head on a rock. Let's presume this is an isolated head and neck injury, and let's assume that there's sort of no drowning aspect to this case. In particular, I'm interested in your thoughts on how you'd adjust your medications. Are you going to use fentanyl, blood pressure targets, C-spine immobilization, the best blade to use? Can you comment on how you'd adjust your airway strategy for the, let's call it, isolated head and neck injured patient?
Right. So the first thing that I'm going to think about are just what are the risks that I'm going to try and mitigate here. So step one is I don't want to have hypotension in this patient, and I don't want to have them to be hypoxic. Those are the two things that I do know are going to result in worse outcomes for them. And George already talked about this at the beginning of the podcast. it's not something I'm going to see in the moment. It's something that's going to happen later on. But it's my responsibility during what is arguably one of the more important phases of this patient's resuscitation to manage that responsibly and to be appropriate and to do my very best to mitigate the risk of hypotension, the risk of hypoxia, and to really take charge of that. Then I'm going to move into setting some targets in my head, and I might say out loud to the team, if these are isolated injuries, and people always ask, what are your targets when you have a polytrauma patient that's a bad head and they're bleeding in their pelvis and all of that? And I know you painted a picture of an isolated head, but what I try and do is, what is the greatest physiologic risk right now? If they're posturing and they have a head injury, and I also suspect concomitant bleeding, then I might weigh towards the head being a little bit more of a problem than if they are simply altered GCS of 10, 11, they're moving all four limbs, but they're clearly not their normal neurologic state and they're bleeding, in which case I might prioritize a slightly more or less aggressive approach on keeping the blood pressure up. I might tolerate slightly lower BP because they don't actually have impaired cerebral perfusion. It's actually that they're bleeding into their pelvis, and so you're always weighing risks and benefits. But in a patient like this, I am going to be looking to achieve or probably maintain a slightly higher MAP, because the MAP plus minus the patient's ICP will dictate their cerebral perfusion pressure, and you want it to be somewhere being around 60, 65. So that puts your MAP probably around 80 to 85. We typically use MAP when we're talking about spine injuries, when we're talking about cord injury. We still use systolic often when we're talking about specific head injuries. And I'm not sure why that is, but that's kind of how, when you look up the guidelines, that's how it sort of plays out. So if we're talking about head first, head injury, I do want to avoid hypotension. So the brain trauma guidelines suggest, and honestly, it's a little bit funny with the way they've broken it up by age, but probably somewhere in around 100 to 110 is the recommended, lower limit. What I like to try and think about it is a target range rather than just a lower limit. So I probably don't need their blood pressure greater than about 160 systolic, maybe not even 140. So I'm going to target somewhere in the 100 to 140 range for these patients, typically, if they have an isolated head injury. If I'm focused, I think, they have a spine injury, my focus is going to be maintaining their MAP greater than 80 to 85 to ensure that they have adequate perfusion to their cord. Part of this, and will dictate how I'm going to decide on those targets, is a proper exam. Do they have neuro deficits? This has to be done before you paralyze these patients, because people will jump to intubating these patients. And then I walk into the room and I ask, what was the neuro exam? And it's not clear to the teams that the neuro exam will dictate the subsequent management of these patients, not by me necessarily, in part by me, but very much so by the neurosurgeon. So if the patient has a GCS of 3, or they have focal deficits, GCS 4, they're posturing, this is incredibly important in predicting their prognosis, because somebody ultimately needs to make a decision about whether this patient needs an OR or not, and a discussion with the family. And so it is on us as clinicians at the bedside prior to paralysis, prior to, and typically these patients are getting RSI. We've now moved away from sort of penetrating neck injuries and difficult airways, but these patients are managed, often typically fairly straightforward or routinely from the delivery of the tube. But this is not about that. This is, you have to complete a very brief. We're not talking, you're not a neurologist here. The reflex hammer's not making an appearance. But you have to check the pupils. You have to decide if there's some lateralizing signs. You have to decide, can they localize? Can they get their arm above the clavicle? Can they cross midline? Do they move one arm and not the other? And all of these need to be documented. Don't write GCS. Write what you saw, so that when you talk to the neurosurgeon and the neurointensivist afterwards, they know exactly what that patient was like right before. And that will inform your targets. Like I said, GCS of 12, 11, with no blown pupil, with no lateralizing signs, no posturing, they probably don't have a head injury that is causing them to have, a high ICP. But if they do have those things, I'm looking for pupils, posturing, lateralizing signs, something, those are going to make me change my targets. And so that's how I would approach this. So it's that very brief exam. It's back to the same thing that we talked about at the beginning with neck injuries. Prepare your team, then do your exam, come up with some targets, and then proceed with management. And all into, now we can kind of move on to the actual management of these patients. If there's signs of ICP, of high ICP, then I am going to be calling for 3%. They're going to get a dose of that, 250 cc's, and I'll probably repeat that once if I need to. I mean, monitoring their pupils. I think that a lot of these patients, and I've started doing this, I think they need pre-intubation art lines. If you can't do that, fine, I understand that. There are limitations to that. You don't have enough hands, you don't have enough expertise. Fine, cycle the BP regularly. But the non-invasive cuffs aren't that accurate, particularly in certain instances. And what did we start with this conversation with? We started with, what do we need to avoid? And so we have a tool that will help us understand exactly what this patient's blood pressure is, and that's an invasive art line. And I think that it's really important if you have time, and these are patients that usually you can wait 5 minutes to prepare your team or 10 minutes before you tube them, put the art line in so that I can actually watch and titrate in, like George was talking about. You titrate in your meds too, so that you can see what's happening, what's actually happening in the moment with the amount of drugs that you're giving so that you mitigate hypotension. And then I will, I often use ketamine and rock in these patients. We haven't had etomidate around for a little while. It's been on back order, so we haven't been using as much of it. I'm okay with either. If they're on the higher side and it's, in terms of BP, I might use propofol, and I don't think that there's any other concomitant bleeding. Again, these are all just sort of, I don't think being dogmatic about this is the right way to go. What I have started experimenting with a little bit more is pre-induction fentanyl or kind of peri-induction fentanyl. And when I have time, I will give 200 or 300 micrograms of fentanyl in advance. The data is not strong to support that. I've done many intubations without that approach, but I'm experimenting to see what happens with their BPs, sort of how do they respond, what happens during these, and overall it seems to be positive. When I give that, though, I give clear instructions to the team that me giving this preemptively, before we've actually started the RSI component, might cause them to be apneic, and I have to be prepared to then suddenly act. Once the patient's tubed, the management continues. It does not stop. In fact, that's when you should be dialed in even more. Tubes passed. Now, head of the bed, if it hasn't already been elevated, it should have been, but I'll put them in some degree of reverse Trendelenburg, or just break the bed and put the bed up at 30 or 40 degrees. 3%'s going in. I'm targeting end tidal, usually normal, but if they have blown a pupil, I'll target between 30 and 35. And propofol infusion usually is what I'm using because I want to be able to turn it off. And if that means I have to backstop it with norepi, that norepi's already running or ready to be run. And I have an art line, so I know exactly what it is that I'm targeting. And so we can't understate the impact that we can have, the potential negative impact on these patients during intubation. And I think it's really important that we stress how important it is that we really look at these patients' hemodynamics during the 10 or 15 minutes of the intubation.
All right, so the underlying theme here with the head injured patient is avoid hypotension, avoid hypoxemia. If people like numbers, you're targeting a systolic blood pressure between 100 and 140 for the head injured patient. For the spinal patient, a map of between 80 and 85. Consider fentanyl 200 or 300 micrograms prior, but be alert for apnea. Consider 3% normal saline. The positioning is going to be vital. Of course, you want these patients to be at 30 degrees head up whenever possible. And then don't forget afterwards that they're going to need some proper sedation, and propofol infusion is a fair choice there. Dr. Kovacs, any pearls or pitfalls to add when it comes to the presumed isolated head and neck injured patient?
You need appropriate monitoring. And I'm not going to talk about what Andrew's already stressed, and I couldn't agree more, is that you want to monitor their blood pressure from minute to minute without having to cycle through it and all the problems you can have with different size arms, etc. but the most critical tool for monitoring adequate oxygenation is having waveform capnography. We think about waveform capnography as being an after device, after you've tubed, whether you're in the right place. But it tells you whether you've got an appropriate seal, and therefore you are delivering what oxygen you think you're delivering. And I've been in situations where they say, walk in the room, they've got a BVM that they're pre-oxygenating with, got nasal prongs underneath it. And they said, well, we can't get the sats up above 90. We're just going to go ahead and pop this person off to sleep and do our RSI. And I said, hang on for a second. Hook up your waveform, you hook up the waveform, and they don't have an adequate seal. And with a couple minor adjustments, they've got a great seal. And lo and behold, their sats come up to 99%. So right now, both of you, all three of us, hopefully have sats of near 100%. But if I were to give you ketamine and rocuronium, you would critically desat to a sat of under 80 in 90 seconds. And so oxygenation tells you nothing about whether you've pre-oxygenated your patient. And waveform doesn't necessarily mean there's end-tidal oxygen, but it has its problems. But what I really want to make sure is that the device I'm using is going to ensure that I'm giving what I'm assuming I'm giving, which is 100% oxygen. And you need to be able to know that with a seal. And if you have your BVM as part of your pre-oxygenation, which most of us are going to do in the stages that you do that, it also tells you that during that phase 2, or in other words, once you push the drugs, whether you assist the patient, you get your numbers and you can see waveform, which is something that's a relief. When somebody desats to an ungodly number, okay, what is our response? Our response is to hyperventilate them, drop their CO2, and we know that hyperventilation is also something that affects morbidity and mortality. So we need to recognize that. You will reoxygenate a patient. You will reoxygenate a patient within 4 to 5 breaths, and especially if you've got a PEEP valve on, right? Within 4 to 5 breaths, you've done your reoxygenation. Everything after that really is affecting their CO2. So I've said this before, and let's just imagine that we're going to do 6 breaths, right? Because I said it's 3 or 4. So 1 breath. Petra, what did you have for breakfast this morning?
Some coffee and a smoothie.
Okay, nice. 2 breaths. That was 10 seconds. Okay. So just imagine us sort of saying, okay, let's do 6 breaths a minute. None of us are able to do that, but the message is simple. Don't go crazy, right? And look at the waveform, because we know this pulse ox lag is that when the sats fall, it's going to take a while. And I said, that's fine. Just look at your waveform. The room is calm. It's also my trigger point that we need to do something now. So waveform is bad and our sats start to fall. Your brain needs to be, everybody's dialed in by those 2 things that we're going to be going to front of neck unless we rescue it by placing a supraglottic airway or something else. So the point is here, use waveform throughout. It's as important a monitor as blood pressure monitoring. And let's just say this, is that, oh, do you remember that case last night? George couldn't intubate that person, or they had a cardiac arrest. Everybody remembers that event, right? They're talking about it. But does anybody ever say, did you hear about that patient last night? Yeah, their sats dropped to 60 for 17 seconds. And their blood pressure, we couldn't get it for 20 seconds. Nobody talks about that. But if you follow these patients out, as they did in the Intube study and other, these patients have worse outcomes, increased morbidity and mortality. So the small shit matters. Pre-oxygenate your patient, right? Resuscitate your patient before you do anything. And norepinephrine is not a bad or a dirty word in trauma patients, regardless of scenarios. As long as you're not using that ahead of doing what you need to do, giving blood, splinting things, putting your hand on shit that's squirting.
So the take-home message there is that appropriate monitoring is essential, especially in the head-injured patient. Understanding that avoiding low blood pressure and low sats is really the key here. Therefore, appropriate monitoring is key, waveform capnography, and if you can do it, an art line. If you have those 2 things in place, then you know exactly if you're avoiding the dreaded low blood pressure and low sat in your head injured patient. I want to talk about a very closely related patient to the head injured patient, and sometimes there's a lot of overlap, and that is the agitated patient. We touched on delayed sequence intubation a little bit before. Dr. Petrosoniak, how do you alter your airway strategy in the trauma patient who's uncooperative or violent or just freaking out? Do you do straight up delayed sequence intubation? Do you do something else? What's your approach?
Yeah, I mean, the first question I think is, do I have IV access? And sometimes these patients come in, they're agitated. They've continued to be agitated because EMS hasn't been able to get IV access. My priority is to get control of the situation very quickly. And I may have to do that without the luxury of IV access. And I'll move very quickly to IM ketamine for these patients. And Ruben Strayer's talked a lot about how to manage agitation in the ED. And I think, you could direct people to that. And on the one end of this sort of highly agitated, super dangerous patient, you simply just need to take control of this situation. And I will use somewhere between 200 and 400 of IM ketamine to get rapid control. And then with a goal of very quickly, like my next step is just get an IV, because you can't do anything safely without an IV. And so really that's the kind of the main priorities. Once I have that, then I can kind of pause a little bit because I can control that approach. And yes, it will be some degree of a delayed sequence. I've never thought about it quite in that way, but this idea that, okay, now I have an IV, I have this patient now chemically restrained to some degree. They may still be somewhat agitated, but I can manage that with further medication. I want to get a sense of their neuro exam. I want to see what injuries they might have and ensure that my team can do the right work. So I'll probably continue. Typically, you need to get some vital signs. Like, do you have, are they still profoundly hypotensive? Or, even if they're that agitated, they still may have a critical hypoxia. And that, in fact, it might be the critical hypoxia causing their agitation or contributing to it. And so I want to get vital signs very quickly, and I want to get IV access very quickly. And so those are kind of the two priorities. How you do that, I mean, my success has been highest with ketamine. It seems to be sort of the most reliable and kind of best option in these cases with the least amount of downside. I'll be honest, I've increased my use of midazolam in conjunction with ketamine over the last few years, just small doses to kind of mitigate some of the lack of being able to chill out when you get a bunch of ketamine. Often these people have concomitant drugs, illicit substances on board. And so midaz, separate from propofol, I just find is, a couple milligrams of midazolam goes a long way together with the ketamine as I'm sedating them. And then, yes, like as you're doing that, the plan is pretty clear to the team. And if it's not said, it should be said explicitly, we're going to be moving towards an intubation if we're concerned about this patient's head injury, or we can't safely manage them into CT because they're simply just unable to be sedated adequately enough, safely enough. And yes, we'll move towards intubation. And that's those are the decisions we talked about at the beginning. But I'm a proponent and I do use ketamine fairly liberally in these instances.
All right. So not so much different to any agitated patient in terms of your approach, except that in the trauma patients, of course, it comes back again to we really need to be careful about their blood pressure and their oxygen saturation are more likely to be abnormal than other kinds of agitated patients.
And my approach to ketamine is that you want to be in that sweet spot, but if you end up in that subdissociative 3 doses analgesic, recreational, and then dissociated, and in that mid zone, the treatment is to give more ketamine, right, to get them through that. And that's why giving it 20 milligrams at a time to titrated effect is that you'll move them through that potential crazy period. And that crazy period is I can deal with. What you have to realize is that ketamine will increase tone. And they actually become posable sometimes. You put their arm up and it'll stay up, but that's why it's not a great drug for using for airway management perspective, is it increases tone. So it is a drug that can be used for analgesia, can be used for agitation, it can be used for preparatory as part of a DSI. It's a valuable drug that we should all know how to use and be comfortable with.
We've talked about the soiled airway. We've talked about the head and neck injured patient. We've talked about the agitated patient. I want to move on to the facial smash, and these can be really scary. Dr. Kovacs, what's your airway approach to the patient who's sustained major maxillofacial trauma?
Most patients with a significant facial smash are significantly altered. Somebody with a facial smash is uncommon to have no head injury associated with it. So they're obtunded and they're a supine position because they're collared. And the fact that you're dealing with a soiled airway, which we talked about before, is just really dependent blood from the maxillofacial injury falling backwards. And that gives them obviously an unpleasant scenario for the patient and will compound any hypoxemia. So you have to recognize that you're going to have to deal with large volume, potentially blood. So you're going to have two decanto suctions available. That epistaxis is going to be an issue. If they have a mandibular injury, it actually means that they're unable to sort of control their tongue, and their epiglottis. So things will, from a gravity perspective, fall backwards, right? And they can functionally obstruct the airway. On the opposite side, they are very easy from a laryngoscopy point of view because they've got a pseudo-articulation that allows you to move things forward and get to where you need to go. But there's no way you're going to really know that beforehand. If you can use positioning as an advantage, then still putting them as upright as you can for that, not fighting gravity for the reasons I just mentioned. And this is the classic scenario for a double setup. You're not going to be able to do an awake intubation in the traditional sense in the majority of these settings. And a crashing patient, and going to end up doing an RSI, and if things look messy, somebody's already at the right side of the bed, depending on what you train to do. The neck's been prepped or not, and even marked. You're going to do your crike if you're unsuccessful from above. And if the patient comes in and they're not in extremis, then you can consider ketamine facilitated situation. And ketamine facilitated for me with a laryngoscope can be a challenge. Ketamine facilitated with a flexible scope is easier to move through space, but you're fighting against your number one enemy, which is blood. And so you have to pre-suction any of these patients as much as you can. If they're not able to be cooperative, then again, it's going to be a judicious use of a RSI. Why is RSI scare you? Is that facial smash means that you can't apply our usual things in the face. So skipping the face. So when I skip the face, if somebody's got a big beard, I don't try to mass ventilate them. I'll skip the face and put in a supraglottic airway, an iGel. So if you've got a facial smash and you need to oxygenate that patient, and not an unreasonable approach is that you can, if they tolerate, and they might tolerate with ketamine, might be able to tolerate even putting in a supraglottic airway. Or again, that's your go-to once you induce them, right? Is to put in that supraglottic airway, avoid the facial smash, and then proceed with video laryngoscopy and good suctioning and managing a soiled airway.
All right, so general approach to facial smash, maybe a supraglottic to start, or just go straight to RSI with a video, and you will have a soiled airway. So all the stuff we talked about for soiled airway applies. Fantastic. So we've covered a lot of ground here, talking about general airway management in the trauma patient. We've talked about airway management when the airway itself has been traumatized, covered so many things from soiled airways to resequencing the trauma resuscitation, the zones of the neck. Are there any other tips or tricks, pearls or pitfalls, any philosophies, any last quotes, anything you want to leave our listeners with before we wrap up? Dr. Petrosoniak?
I mean, yeah, we certainly covered a lot of ground. I mean, I won't have nearly as good a quotes as George, so I'll leave those to him. But I think if you're not debriefing after these events as a team in some way, whether it's immediate, that would be a preference, or regularly in some sort of informal way, rounds, I think you're missing an opportunity. I think The future also lies with these being video recorded so that we can actually observe what's happening. And I continue to, keep pushing your institution on that as being part of the future. But at the very least, come together as a team to ask questions about what went really well, where's there opportunity for improvement, be objective in that and look at the, what your numbers were. Look at was there ever an episode of hypoxia or hypotension? Was there any way of avoiding that? With what happened, did you predict that was going to happen? If there was a mismatch between what you thought was going to happen and what happened, why was that the case? And so being a bit deliberate in this will make you better over time. And in places where you have a luxury of many clinicians around you, ask a friend to watch your resuscitation. Ask them up front, hey, listen, we have a sick trauma patient coming in. We actually have all hands on deck, but can you come in and just give me some feedback afterwards? And these things can go a long way towards being overall, getting closer to better.
Yeah, talking about watching resuscitations and debriefing, for those of you who don't know, Dr. Petrosoniak is an expert debriefer, and he will be at the EM Cases Summit doing his expert debriefing for our simulations with Sarah Fewey's virtual resus room. I'm very excited for that. If you haven't signed up yet, go for it. Dr. Kovacs, any last words of wisdom when it comes to either the airway in trauma or the airway being traumatized?
Be humbled and be prepared to learn. Not a month goes by where I haven't said, wow, you know what? A new perspective. And it's not because I'm grazing the literature every morning. It's because you're listening to the people who are involved. And I think that's what Andrew's talking about. And take the moments to praise. When I brief the trauma room, I make a very specific comment is that once the medics sign over that patient, thank them for their care. Right. And those little things go such a long way. And we just spend so much time being critical and not enough time, praising the wonderful work that's being done. And if I'm having a conversation with somebody in a remote area, again, it's contextual information. And I'm not lying by saying you guys doing an amazing job. Right. And we have to do that more and be humble, ask for help. Yeah, so that's the big message that I guess I'd have.
Fantastic. And Dr. Kovacs will also be at the summit teaching. Dr. Kovacs, can you give us a little idea of what you're going to be teaching about, just to get us all excited about your talk?
Now, this is going to be a celebration of people who have donated afterlife so that we are better prepared to manage patients during times of crisis in life. So it's about lessons learned from clinical cadaver work, as well as time at the bedside and time from my greatest teachers, those who have donated their bodies. So lots of pearls.
Fantastic. Greatest airway lessons from George Kovacs, our national airway expert. All right. Well, I hope our listeners learned a little bit about resequencing the trauma airway, the indications for intubating the trauma patient, the timing of intubation of the trauma patient, strategies for the scary penetrating neck trauma patient, how to pick up and manage subtle neck trauma, how to alter your airway strategy for a variety of head, face, and neck trauma patients. I'm hoping you can now save even more lives than you're already saving out there. Keep on doing what you're doing and keep on being humble. Thank you so much, Dr. Kovacs and Dr. Petrosoniak, for your brilliant insights into the challenging world of trauma airway.
Awesome, Anton.
Yeah, thanks, Anton, for having me on. It's always a pleasure to chat and share ideas. George has, been a leader in airway management in Canada, and so, being here with him is always a pleasure. And the cases and the content you put out there is great. So we appreciate it in terms of what you're putting out with EM Cases as well, Anton. So thank you very much.